sometimes because the baby's sitting on your bladder, you're gonna pee yourself at home, and you're gonna think that your water was broken, right?
It happens.
Yeah. And so you're gonna come in, and they're gonna do that fetal fibronectin test, and it's gonna be negative, and you're gonna, no, I know my water broke. And that's not something to be embarrassed about. It happens all the time.
You're listening to the Mommy Labor Nurse Podcast, where we firmly believe in the power of education when it comes to giving birth. Tune in each week as we dive into pregnancy-related topics, expert interviews, and a variety of birth stories. As a reminder, anything you hear on this podcast is not medical advice. Please see mommylabornurse.com/disclaimer for more details. And now, here's your host, educator, registered nurse, and fellow mom, Liesl Teen.
Hey guys, happy Monday. So this episode is actually part 1 of a 2-part series. I guess we can call it a series, but basically Lindsey and I decided to do a 2-part episode because we just wanted to talk a whole lot about a lot of different things, and we felt it was best to split up these episodes. So if you guys don't know who Lindsey Shipley is, you guys are going to love her. I'm sure if you know anything about breastfeeding, or if you're interested in breastfeeding, you probably already follow her page. And if not, you should. So she has a pretty big Instagram page. She is at Lactation Link on Instagram. I'm a big fan of her page. She gives a lot of wonderful, amazing breastfeeding tips. And guess what? She's also a labor and delivery nurse. She's not currently practicing anymore, but she's a fellow labor and delivery nurse. So we thought it would be cool to come on here and just go over some terms that you may hear when you go into labor, when you come in for your C-section, when you come into the hospital. Sometimes you'll hear us say things that aren't super familiar to you. So we thought it would be a good episode to just go over all of these different terms. And, who better to do it with than another labor and delivery nurse? So that is part 1. Part 2, if you haven't guessed, we talked all about breastfeeding because she's just amazing at educating other moms about breastfeeding. So we answered a lot of questions about breastfeeding, and she talked about her top 3 tips on how to have a successful breastfeeding journey. So Lindsey Shipley is an RN, a childbirth educator, and an IBCLC. And IBCLC, if you're not familiar with that term, an IBCLC is International Board Certified Lactation Consultant. It is like the best of the best degree that you can get when it comes to lactation. So she knows her stuff. She's also a cancer survivor and a mom of 3. After being a labor and delivery nurse for 5 years, Lindsey saw too many moms feel scared and unsure when it came to breastfeeding. Totally agree with her. That's a big issue. She overheard lots of differing opinions and conversations on the right way or the best way to breastfeed. It's no wonder moms can feel overwhelmed and unsure. Lindsey set out to change all that with Lactation Link. When her second baby was 6 weeks old, she was diagnosed with cancer and went through 2 years of treatment. With education and support, she was able to reach her own breastfeeding goals despite facing that challenge. That's crazy to me. And we talk about it in the episode. I'm actually going to probably have Lindsey on for a 3rd time just to talk about her whole personal journey because, wow, what an amazing lady. That experience made her passionate about creating a breastfeeding resource families knew they could trust when they experienced challenges of their own. Through the Lactation Link online classes and support forum, she has created reliable, research-based information that is also easily accessible. She is based in Utah, but her customer base is everywhere because of her online classes and e-consults. Super cool. Big fan of Lindsey. I've checked out her courses and gotta say, wow, so impressed with her courses. I'm going to leave a link to them in this episode of the show notes and also in next week's episode. So without further ado, let's get into part 1 of this 2-part episode with Lindsey Shipley. Pregnancy and birth come with a lot of unknowns, and I should know, I'm a labor and delivery nurse. What if I told you there was a resource that could support you for every step of the way and prepare you for every scenario, no matter how things play out? It's true. The Mommy Labor Nurse All Access Pass gives you instant access to every single one of our courses and resources in one spot for an entire year. Head on over to mommylabornurse.com/AAP to learn more. I can't wait to see you in there. Hi, Lindsey. Welcome to the Mommy Labor Nurse podcast. Thank you so much for being here today.
Hey, Lisa. Thanks for having me.
Yeah. Can you just start by telling our listeners a little bit about yourself and your family and what you ate for breakfast and all that good stuff?
All that good stuff, right? Oh my gosh. Yeah. Thanks for having me on. I'm so excited. Two labor and delivery nurses coming together to chat all things, my name's Lindsey Shipley. I'm a registered nurse. My background's in labor and delivery. I'm also an international board certified lactation consultant. And I'm the founder of Lactation Link, where we do online breastfeeding and pumping courses. We've had tens of thousands of parents take those classes over the last 6 years. Cool. But I actually never knew that I would be, having a company called Lactation Link. Maybe we'll get into that a little bit later. But I also have 3 kids. I have an 8-year-old, a 9-year-old, and an 18-month-old. So they're, very busy. I'm also a cancer survivor, and I have a story in that regard that we could take a whole podcast episode to go into, but we won't.
That's episode 2, because I would love to hear all about that. And I know my listeners would too.
So that's something that, I carry every day. And I think we all kind of have our own unique challenges in life and motherhood. And I think like none are more important or harder than the others. I think, we just have a unique story, right, to tell.
Right.
And I really, started down this path of this company because I, just like you, have stood at the bedside of hundreds of deliveries. And I just saw that so many women and families were scared and unsure when it came to breastfeeding, and it's not something that I anticipated as a young labor and delivery nurse. I was 22 when I started, and I had no kids of my own. And so I kind of thought, probably like a lot of first time moms think, oh, well, things will just click and, the baby will just latch and all that kind of stuff. And I saw like time and time again, it was more common for moms to feel scared and unsure and not know what to do with breastfeeding than it was for women to feel confident, supported, and educated. And I was just like, wait a second, what is going on? And so I think it was then that I kind of dove and said, okay, well, what kind of resources and what's going to help women be more successful? And I found through research that the number one indicator of breastfeeding success was prenatal breastfeeding course, went looking for a resource that I could give those clients and give to the doctors to put in their offices, and found that everything was outdated and not relevant to the modern parent. So that's kind of that's why we're sitting here today. Right.
That's right.
And so we have those online courses. And I went down that road to get that IBCLC credential, which is a whole other ball game.
Sure.
And we, it's 1,000 hours of hands-on helping moms and babies. And then it's 90 hours of lactation specific training in the classroom. And now we have 25 IBCLCs on our Lactation Link team that do one-on-one consultations and are ambassadors of the courses. So, I found through, building that team that IBCLCs are kind of like service-based people, because and my husband thought I was crazy too. When I said, oh, I'm going to go do this comprehensive course and this exam that's going to cost us like money out of pocket. He's like, okay, so what raise are you going to get at the hospital? I'm not going to get a raise. Are you crazy?
Yeah.
And so typically these are people who are very passionate about helping families reach their goals, because they don't really have any other incentive typically. So it's a really cool group of people for sure.
That's very cool. I didn't realize you had that many people on your team. That is amazing that you have so many people and I'm sure that it makes, sometimes I know with at least online services, sometimes there can be a little bit of a wait to get in with a consultation, but if you have that many people, it sounds like, if you need to talk to somebody today, you can talk to somebody today. That's very cool.
Yes. Yeah. And we've got several people who are bilingual in Spanish. Cool. We've got somebody in India. So we've got a lot of accessibility for sure for people to have those one-on-one consultations, either prenatally, just to kind of make sure they have their birth plan, their feeding plan in place, or those first few days postpartum to make sure everything are going just as they should, or when common bumps arise, or not so common,
Yeah. Because there's a lot of them. There's a lot of them.
For sure. Yeah. So that resource is there.
Yeah. Well, cool.
Yeah.
Well, today, guys, since we are both labor and delivery nurses, you're not still working as a labor and delivery nurse, are you?
I'm not a staff nurse right now. No.
Okay.
But we do one-on-one consultations in the hospital. Obviously COVID threw that for a loop a little bit.
Yeah.
But that's starting to open back up as well.
Very cool. Well, since we both are labor and delivery nurses, we thought this episode would be cool if we talked about some common terms in labor, postpartum, breastfeeding, that you might hear, triage terms that you might hear that you might be kind of unfamiliar with. So we thought we would kind of bust those terms and kind of explain them through, because I think that's something, sometimes I know sometimes, people come in, it happens all the time. Like somebody will come in and I'll say, oh, we got to, do this, that, and the other. I got a IOL. I got, VBAC. I mean, most people know what VBAC means, but we get, we get so comfortable talking in medical language around patients that it's like, sometimes we will say something and the patient's like, wait, what is that? What does that exactly mean?
Yeah.
So we thought it would be good to do this episode.
Yeah. And I think it's, not that you need to be, at the level of, any of the staff, right? And it is on the staff to explain things so that you make sense, make sense to the client, and never be afraid to clarify something. But it can be nice, these terms that are going to be used quite often, if you feel like you're more educated and empowered in that way. So we just wanted to peel back the curtain and kind of say, hey, here's a couple things you may have heard and are wondering about.
Yes, totally. I love it. So we're going to talk about some terms first. And then we also put out a box just a few days ago asking some questions from you guys to see from you all what your top breastfeeding questions were, because God knows there are a lot of them. So once we get to the second half of that episode, Lindsey's going to go through all of these great questions and give some tips and tricks for breastfeeding moms, because I know, I've been breastfeeding mom now twice, and I feel like there's still, even with my second one, there was a learning curve with a lot. Like, I feel like I was still learning stuff as, there's like, you learn so much beforehand. You can learn so much beforehand, like with a course like yours, that is like super, super valuable. But then once you do it, it's like, oh, I'm glad I do have this online course that I can refer back to, because I have so many questions.
And you got a chance to take a look at the courses. Have you wiped your tears yet from that? I did.
Oh my gosh. I know. It was so good. You guys definitely have to check them out. Like, we'll leave a link in the show notes page for anybody to check out. Anybody to check out the Lactation Link courses. But yeah, the one that Lindsey sent me before this was so, like, I wasn't expecting to get a little teary-eyed, but I definitely did. I was like, oh my gosh, this is so sweet.
And it's, the one that you watched was a video of right after birth, and just those newborn reflexes coming out, and how, how baby is like hardwired, to find the breasts and things. And, obviously people have taken those all over the world, but whenever we've been able to do in-person training, I don't watch the video. I watch the families that are being, that are at the class, and like, they're always like tearing up. They're like making little noise, like, because it is just a really beautiful event, and it doesn't have to go in perfect sequence. Everybody's journey is going to be unique. But we can rest assured that babies were made to do this, and our bodies were made to do this.
Yeah, totally. Love it.
Yeah.
All right, cool. Well, that's going to be the second half of the episode, so stay tuned. So let's start off with some terms. Lindsey, I'm going to let you go first. We kind of grouped these into different sections. So Lindsey, I want you to start talking about some of the terms that maybe someone would hear when they first get to triage, first come up to labor and delivery. Yeah,
perfect. Love it. Okay. So the first one we have is EFM. And that stands for external fetal monitoring. So typically what'll happen is you'll come in, you'll get a gown on, and they'll have like maybe a couple bands, like belly bands, that they're going to use to hook some external monitors. They're usually like a little circle. There's going to be one for the contractions and then one to measure baby's heartbeat. Okay. So that's your external monitoring. And I think we'll talk a little later if internal monitoring is needed, what those terms and things are. Oh, no, it's right here. Yeah. Internal monitoring. Okay. So internal monitoring. So if you're being monitored and for some reason there needs to just be a more definitive kind of look at your contractions and also at baby's heartbeat, because the external monitors do a good job, but sometimes they fall off, or sometimes they need adjusting, or they don't give like the clearest picture. And so if you need internal monitoring, that's going to be referred to as an IUPC or an FSC, a fetal scalp electrode. And so those are, need to be done by your nurse, and you need to be obviously explained, pros and cons of those. But that's the difference between kind of monitoring there. And, maybe a reason that you would need internal monitoring for baby is if we're starting to see distress, or we're starting to see what we call decelerations, later. And so that's a little bit on monitoring. FHR is just fetal heart rate, or you might hear nurses refer to it as heart tones, right? And now what about some little tests that nurse might do when you come in? So if you come in for triage, they're going to obviously monitor baby, and then they're going to check your cervix, because they want to, think if you're see where you're at, like in that labor process. Right. And we always say, there's nobody you get to know faster than your labor and delivery nurse.
That's true.
Because they'll come in and they'll say, hi, what's your name? And then they'll go down to check your cervix. Right. There's not a lot of small talk, right? Or beating around the bush there. And so figuratively and literally. Okay. So,
I was just going to say,
okay. So that is the abbreviation for that is SVE, which stands for sterile vaginal exam. Okay. And then I'm going to come back up to the other one, but there's another thing called Leopold maneuvers, which is where your nurse or your doctor or your midwife would put their hands on your belly and try, by different, I guess, how they're feeling it and how they actually can watch the belly in different positions, are going to be able to tell where the baby is positioned inside. Right.
Yep.
And so that's what Leopold maneuvers would be. And then another test, and sometimes they'll do that throughout the whole labor, right? So and that's actually a really good thing that they're doing that. It's a great sign that they are actually trying to actively monitor the labor and help through positioning and different things, baby get in a position that's going to be easiest for them to come out, right? And so that's actually a really good sign. Okay, another test they might do is called fetal fibronectin. And that's if you come in and you think that your water's broken, but they're not able to see any gushes or just like clear signs that water's been broken, especially if you are preterm, right? Because we don't want to do any interventions or help baby get there unless that water has truly been broken, because then obviously we're worried about infections and things like that.
Right.
And so sometimes, and I've heard lots of my friends, it's nothing to be embarrassed about. Sometimes because the baby's sitting on your bladder, you're gonna pee yourself at home, and you're gonna think that your water was broken.
It happens.
And so you're gonna come in, and they're gonna do that fetal fibronectin test, and it's gonna be negative. And you're like, no, I know my water broke. And that's not something to be embarrassed about. It happens all the time. But sometimes you're going to come in and it's actually not going to be broken. And it's just going to be like a little urine that came out. And then sometimes you're going to come in and it is going to be broken. But I think it's good that they take that extra step. So there's not unnecessary interventions. But also, if the water is broken, we're going to protect you from infection and things like that. And if you have anything to add to any of these, Lisa, be sure to hop in. Okay. And then talking about the cervix, you may hear that you have a favorable cervix or an unfavorable cervix. And all that really means is, has the cervix kind of shortened and thinned out to where we feel like either when you go into labor on your own, or we do like an induction with something called Pitocin, how likely is that to be effective, right? Or how likely is that going to be able to help you? Or, is your body just not in the right place to get something like that started, where even if we do start it, you're not going to progress in labor, right? So we're talking kind of about the state of your cervix, right?
Yep.
And so if an induction needs to happen for a medical reason, but the cervix is unfavorable or it's not ready, right? They might use some techniques to do what we call cervical ripening. So that's another term to kind of think about. I mean, think about an avocado that's not ready to be made into guacamole, right?
I was going to say avocado, or I did a video a little while back. I saw it originally on TikTok. A couple people had done, I've seen a couple of videos on TikTok, but same kind of thing, but it was a banana, like thinking about peeling a banana and how that green banana is really, really, you can still peel it, but it's much harder and tougher. And then riper banana is yellow. It's a little bit easier to peel, but like think about that brown banana, how darn easy it is to peel. It just like basically falls apart. So when you think about your cervix and it being favorable versus unfavorable, think about, a banana, or like you said, an avocado is another great fruit, or I guess is avocado a fruit or a vegetable?
I think it is a fruit.
I think it's a fruit, right?
We're not an expert on that. We'll tell you about labor terms all day, but let's not
we don't know about
unfamiliar territory there with fruits and vegetables. So think of, something like, we'll call it a Cytotec induction or a Cervidil induction. Those are medications that they kind of put next to your cervix. It's kind of like, think of like if we had a magic wand that you could wave on the avocado to make it ripen faster. It's the same thing with your cervix. Do you guys use any other methods for cervical ripening at your hospital, Liesl, other than Cytotec or Cervidil?
We don't even use Cervidil anymore. We use Cytotec. We obviously use Pitocin, but we use Foley bulbs actually a ton. So that's on medication, but that's a I guess you can, that one's actually, we didn't list that one, but why don't you explain what a Foley bulb
later?
is?
Yeah.
I might have listed it a little bit later. Okay.
I don't know why, but yeah. So
you're right.
Foley bulb, you would, so it's like, if you were going to put like if we were going to put a catheter in, right?
Yeah.
If you would need that for some reason, we'll do that in a Foley induction. And then we'll kind of manually try to open the cervix there. And that can be really successful in a lot of ways. So it's just going to come down to what's best for your history, what's best for your body. And you talk about that with your healthcare provider if it's needed. Hopefully it's not, but if it's needed, then basically make the best choice for you, right?
Yeah.
And then we have something else here. So there's PPROM, PROM, or SHROM, and all of these have to do with your bag of waters or your membranes. Okay. So that's just kind of the cushion that baby lives in, the water, that whole 9-10 months that they're cooking. Right. So, that gets kind of confusing here. So we've got two P's ROM. So preterm, premature rupture of membranes. Yeah. Okay. So if your water breaks before you even go into labor and it's earlier than 37 weeks, that's called a PPROM. Okay. Yeah. And then when it's just PROM, it's premature rupture of membranes. So just before you go into labor, 37 weeks, or, if you're past 37 weeks, that's how they would categorize it and write it down. And then spontaneous rupture of membranes just means that your bag of waters broke, while you were in labor. Right.
Yep.
And then the other one is AROM.
I was going to say, why don't you say AROM while we're on the ROMs?
Yeah. Another one is AROM, which is called artificial rupture of membranes. And that's actually, we didn't mention that, but that can be, I guess, another way to induce or augment labor, by just saying, hey, we've got, pretty favorable cervix. Let's just see if we can kind of jumpstart the labor by artificially rupturing the membranes. Yep. Or if you get started in induction and you've got Pitocin a little bit and you're making a little bit of progress, it's just, can sometimes your provider is going to just artificially break your bag of waters as a part of that induction process.
Cool.
So that's our kind of triage list. I'm sure it's not,
love it.
We've probably missed a few little things, but those are kind of the most common things you might hear during, during that time.
I think you did a perfect job. So I'm going to move into some of the labor terms. So I thought I would probably actually start off, you just kind of left off with AROM. So I'll talk about some of some of the induction ones first. So first of all, when we talk about inductions, sometimes you'll hear the term IOL, which means that stands for induction of labor. And sometimes moms are induced medically. So you'll have a medical IOL, induction of labor, or you'll have an elective induction of labor. Medical ones, I would say probably are most common. But a lot more moms are electively deciding to be induced these days, thanks to the Arrive study, which I've done a whole podcast episode, I feel like, on that. It took up like half of a podcast episode. So a lot more moms are choosing to get electively induced because that Arrive study did show that at 39 weeks, your C-section rate, it does go down a bit if you're induced electively at 39 weeks, but there's a whole lot more that goes into that study.
Yes.
So go listen to that episode. I'm like, which number was that? I'll have to plop that into the show notes. But anyways, so that's IOL, medical versus elective. And then sometimes when I have an induction mom, I'll refer to your Pitocin, which is the medication that you get during your induction to make your uterus contract. I'll refer to it as PIT, and you'll hear your nurses refer to it as PIT. You hear your doctor, your midwife refer to it as PIT. That's just a short name. We just like to say PIT versus Pitocin, I guess. So those are kind of some of the induction terms. I'm trying to see if there was any else on here. I think we're probably good. So let's get into some of the cervical terms. So there are a lot here. So first, when we talk about cervical checks, I know, Lindsey, you talked about just cervical exams in your triage part, but let's talk about like what dilation means and what effacement means and what station means, and then anterior versus posterior cervixes. So dilation is basically how, wide, how big the opening is. Okay. So your cervix, starts out at no centimeters, 0 centimeters, and it has to get to 10 centimeters to come fully open, to have baby, come through and birth and come out. So dilation is how open your cervix gets. And then effacement, when we talk about effacement, think about your cervix. It's kind of like if you hold up your fist. So it's kind of like thick and long, and effacement is basically where it's thinning out. Okay. So the cervix not only has to open, but it also has to thin and get really, really soft. Okay. So if we talk about effacement, you might hear your provider check you and say, oh, you're 4 centimeters dilated. So you're 4 centimeters open and you're 80% effaced. So that means that 80% of that cervix is thinned out. So there's only about 20% left. So that's what you would hear, if your provider would check you.
One thing I would mention with effacement, because that was the hardest part for me to visualize as a labor nurse when I was first learning. And someone told me, think of those little powdered donuts, the white powdered donuts, and think of it just kind of like somebody stepping on it and it just getting flatter and flatter and more pushed out. And that was the first time I was like, oh, okay, I get it, because that can be really hard for people to understand. Like, it's kind of that thick donuts. And then as we mash it down, it gets thinner and spreads a little bit thinner.
See, you just gave me a real idea, Lindsey. I'm gonna tag you in my next reel when I'm explaining my donut cervixes.
I love it.
I'm used to Play-Doh. I usually do my reels like with the cervix. I've done Play-Doh a lot, but I love that. Yeah. So anyway, so the third one when we talk about cervical checks is your station. So that's just where baby is in your pelvis. So we talk about station is a little bit hard to understand, but there's basically like a bony prominence in your pelvis, and it's called your ischial spines. So that place is where your station is what we deem zero station. Okay. So if baby is above that that bone right there, baby is still in negative stations. So it's, I wish you guys could see my hands and like how it's working, but basically you're at zero station. Most people I would say are at zero station, not during their pregnancy. You're usually at zero or the plus stations, once you start labor, but zero station is where that pelvic bone is. And then you go up. So -1, -2, -1, -2, -3, -4, is, -3 and -4 is kind of where baby lives, during pregnancy, not in labor, not engaged or anything. And then as baby comes down, you go from, -4, -3, -2, -1. We're starting to say, okay, baby's, starting to get nice and engaged in your pelvis. And then baby hits zero station. And then once baby passes through zero station, we talk about the stations moving to plus. So +1, +2, +3, +4, AKA on the floor, baby's out. +4 is like baby's head is hanging out. So that station, it's kind of hard to visualize without a chart. And I like to always, like, whenever somebody asks that in story questions, I always pop up, there's like a nice little Google image where it, you can see the baby really, really well in the pelvis and how stations work. So,
and thinking a little bit about an elevator, right?
Yes,
when you're thinking about those numbers going up and down. Just thinking about, okay, if it's higher, it's higher in the elevator, it's going to be that negative and then kind of coming down. And then
you got
when
some
baby tried to come out, that elevator is going to open, right? And they're going to come on out. So
that's right. I love it. You got some good visualization metaphors, right?
Yeah.
Are you in search of the perfect pump for the breastfeeding days? The Motif Medical Luna is a powerful breast pump built for modern motherhood and covered by insurance. Now battery powered to give you more freedom and flexibility, Luna's rechargeable battery lasts over 2 hours. It's also got a super simple setup and easy customization option so you can quickly find out what works best for you and your baby. The Luna features a backlit LCD screen, built-in nightlight, closed system, quiet motor, and auto shut off. It's also super lightweight, weighing in at just 2 pounds. But beyond the features and ease of use, the Luna works. In a third-party study, 5 out of 6 moms reported more milk in less time with Luna. One major reason why 90% surveyed preferred the Luna over their current pump. As a pumping mama, I personally used and loved my Luna pump. The massage and expression mode provides full control and maximum comfort. These modes stimulate letdown by mimicking your baby's natural nursing pattern and expresses milk from the breast with high efficiency. Sophisticated, strong, soothing, and covered by insurance. Get ready to make your pumping days easier with the Luna. To learn more about the Luna and order one for your breastfeeding and pumping journey, head on over to motifmedical.com. And now let's get right back into this week's episode. Well, let's talk about anterior versus posterior cervix. So this is not part of your cervical, like official cervical exam, I would say. But a lot of times what happens when you're in labor is your cervix will go from being posterior, kind of back in your vagina on the backside. And then as you're in labor, it comes forward and it comes anterior. So if you think about your body and how like the planes on your body, posterior body, your posterior plane is your backside. Okay. And your anterior plane is your front side. So your cervix, if your provider is saying, oh, your cervix is kind of posterior, it just means it's kind of back, kind of towards your butt. And then as labor starts, typically your cervix does come much more anterior, much more forward. Your vagina is an odd, not in a bad way, but it's an odd organism where the cervix does, it's not just like in one place. It does kind of move in labor. So that's kind of hard for people to understand.
Yeah. I think, and then keep in mind, if your cervix is posterior, the nurse might ask you to, like, they might put like a little basin under your bum, or they might ask you to put your fists under your bum so that they can reach the cervix easier without killing you, right? When you have that posterior position. And the other fun tidbit I would add is I have a uterine didelphys. So I have actually 2 uterus.
Oh,
So
wow.
I actually have 2 cervical openings, believe it or not. How
Wow.
crazy is that?
That is crazy. I've heard
so
of that for sure, but I've never met someone with that.
Yeah,
So cool.
It's not super common. Yeah. So my first, which was a vaginal delivery, they could check my cervix on both sides, which was like trippy and weird, but just as a little side note. And now I'm like TMI, but nothing's TMI with us, right?
No, never. Yeah, no, that's pretty cool. So yeah, that's definitely a thing, guys. Fun fact.
But probably not going to happen to you. So
probably not going to happen to you. Probably not going to happen to you, but that is a thing to have 2 cervixes and 2 uteruses. So let's move into some of these other labor terms. So the next one we can talk about is preterm labor, PTL. And I would say my facility doesn't really we don't really say PTL, but you might see it in your chart, like preterm labor here for, PTL, preterm labor. So that's that one. And then let's talk about unmedicated versus natural. And this one sometimes gets a bad rap. And I actually have a full lesson in our birth courses in my natural series. Because I get a lot of people saying, why do you say natural? Why don't you say, just unmedicated? And it's tough because I agree. I hate the word natural. I think I wish it wasn't, a thing, but it is, when we talk about giving birth without epidurals. And unmedicated, I would say, if you're looking to go without an epidural and you're looking to go without any IV pain medication or without any gas and air, nitrous oxide, that's what I would deem unmedicated, someone looking to go unmedicated during labor. And then natural, I think probably falls under that same umbrella. But, if I say, if I have a mom who's saying I'm, looking to go natural, maybe she is interested in, other pain techniques other than epidurals. Maybe she wants to get some IV pain medication. Maybe she wants to try some nitrous oxide, but unfortunately natural is not, it's just a sensitive word. People don't like it, which I totally understand. But it's just, I also, so I say this in the course too, I also am not a fan of only saying unmedicated when I refer to that type of birth, because Pitocin is a medication and you might want to get induced and, go unmedicated when, you're trying to get induced, but not get IV pain medication, but get, it's like it, but you are medicated because you have Pitocin run. It's like, it's such a weird, and I'm sorry that there's so many terms, but it's like,
I think that there's, another like discussion point that women will bring up, like, okay, I had a C-section delivery, but is this not
natural?
Like just that natural term is just kind of like this elitist type approach to quantifying it or categorizing it. Right. And I think whatever birth ends up being the right one for you, you can consider it a natural birth, right? Like, I think that's a discussion point. And I think also when people come and the terms they want to use, whoever's educating them will typically use the terms that they want to use. Right. We're not going to correct you or say, no, you have to use it in this way. If you're, so it can be kind of a unique approach. And when you see it, it doesn't necessarily need to be offensive. Like, oh, okay, well, if I'm having it this way, does that not mean it's natural? Right. Try just to feel out what's going to be the right term for you. And then go with that. That's kind of what my input on that, but it can be misconstrued and misunderstood and whatnot.
Yeah. Agreed. All right. Well, let's go into a couple other more terms. So this next one is BOW or BBOW. And again, I don't ever say BOW, but BOW, if you see that in your chart, is just bag of water, and BBOW is bulging bag of water. And that's what we, we'll talk about. Just your amniotic fluid is your bag of water. So you might see, BOW, and then bulging bag of water is, if your provider checks you and does a cervical check, and they can really feel that bag of water bulging against your cervix, and it's like about ready to pop. Sometimes we'll call it a bulging bag of water, just, instead of just your bag of water because it's bulging in there. So next ones, we'll talk about VBAC versus TOLAC. So most people, I would say, if you're looking to VBAC, you know what a VBAC stands for, vaginal birth after cesarean. But a lot of people just don't realize that there is a difference between TOLAC and VBAC. So TOLAC is trial of labor after cesarean. And as far as I'm concerned, trial of labor is the attempt, VBAC is the success, right? If I'm off on there.
Yeah, that's how I understand it too.
Yeah. And sometimes they get interchanged. I definitely am guilty of that, doing a post on TOLAC and using the word VBAC, but really the technical way is like, if you're talking about attempting, it's TOLAC. And if you talk about you've had a successful one, it's a VBAC. So, all right, go ahead if you had something.
Oh, you're great. I was just going to say, if you had a successful one, I think on your subsequent birth, you could just call it VBAC from the start. Is that right? Okay.
I think so. Yeah. Again, see, we're quizzing ourselves.
We're quizzing ourselves on that one.
All right, let's move into a couple of these other ones. So let's talk about like, you're getting a little bit deeper into labor. So transition. So a lot of people, want to know kind of so first of all, if you talk about the stages of labor, the stages of that first, so there's technically 4 stages of labor, but that first one is when you're dilating from 0 to 10 centimeters. And then that one is broken up into a couple different, 3 different subsets. So early labor, active labor, transitional labor. And transition is basically that last subset as you're getting deeper and deeper into labor. I would say it's not necessarily like a stark number, like once you hit 7 centimeters, you're in transition. Once you hit 9 centimeters, you're in transition. I would say it's probably more, and you might disagree with me, but I would say it's probably more on how mom is acting. Because you just start your mentality, your physical, you just start to change. You get very emotional. You get very, you're just kind of, I have a post that I did where it was like early labor is you're, kind of smiling, kind of not smiling, kind of like, okay, like this hurts. I'm breathing through them a little bit, but like, okay, I'm excited. I'm in labor. And then active labor is like, okay, you're not really smiling anymore. You're not laughing at jokes. This is like serious. This is not going away. And then transition is like your crazy face, like, oh my God, when is this going to be over? Blah. You're just saying things that, you don't, as I've gotten called the B word a few times. People in transition. I mean, you say things that you don't mean. It's totally fine. Everybody does it. I've done it during labor. You just scream or do crazy, acrobatics or just crazy things. So that's what I would say transition is.
And if you're planning no epidural, this is typically the time that you ask for the epidural.
Yes. So let's talk about this next one, failure to progress. And you put a note on here that you hate the word, this way this is worded. And I would agree with you that I do too. There was a post that I shared back when Peanut was doing their whole, they shared this campaign. Did you see that? They shared all of the failure. Yeah. So there's so many terms.
Kind of negative language.
Yes. Negative language. Yeah. And a few of them were like failure to progress or failure to descend, or there's just a lot of medical terms like that are very negative. So when we talk about failure to progress or failure to descend, it's usually in your chart or your providers saying that if you've attempted labor and your cervix has you've stalled at a certain centimeter, and then it's deemed that it's necessary to have a C-section. So your provider might say, okay, you're a failure to progress. Let's go back to the OR, or you might see it in your chart or on your bill, once you get your bill afterwards. And I would agree that this is bad. I want to change the language. I want to at least change the bedside language. I think we can start with that at the least, you know. It's harder to change medical terminology when it comes to billing and, what you see on your, on your bill afterwards. And there's so many other terms out there that Peanut did a fabulous job with that campaign of highlighting all of those terms. But yeah, I would say I definitely would love to start with changing the bedside terminology.
And I guess the way I look at it is more of it's like, it didn't work in this way, but that's why we have plan A's and plan B's, right? Because we're all unique, and different ways are going to work. And thank goodness we do. I have 3 kids and I'm 2 times C-section, and I'm grateful, for that, option as well. Yeah. I just don't like the kind of label it puts on like a mom, like her body failed or that, she failed in some regard, because there's no truth to that. It's just that we had to go to a different plan. Yeah.
And it just sets you up for that mentality, that negative mentality. There's already we want to honor all moms giving birth, and especially honor moms who have belly births, have C-sections. And when you have these terms placed on these moms, it's very heavy. So, the next one is rest and descend. And I want you to do that one because I don't use that term.
Okay.
Do you mean, see, now I'm like,
no, you're good. I'm just talking about maybe it's a first time mom. Okay. Yeah. And she gets to 10 centimeters. We're not necessarily going to push right away based on where baby's head is. That's all I'm talking about. So maybe you use a different term.
Oh, I say laboring down.
Yeah. Same thing.
Yeah. Okay. So laboring down, rest and descend. Okay, cool. Hey, learned a new term. Love it. So laboring down is what we call it, but it's the same thing. Rest and descend is basically if, like you said, if you're a first time mom, sometimes it's second time moms, but I would say probably much more often with first time moms, you get to 10 centimeters where you're fully dilated. And I would say most of the time we use this practice with moms who have epidurals because it's kind of hard to rest and descend or labor down when you don't have an epidural. But if you have an epidural,
probably less necessary too.
Correct. So if you have an epidural and maybe you've got, you're starting to feel a little bit of pressure, maybe your providers, just checked you and you're 10 centimeters, but your baby's still a little bit high in your pelvis, still maybe at that 0 station. And what we do is it's called laboring down or rest and descend. And we just kind of let you chill, let your body push your baby down with more contractions, push that station down, and then let baby get a little bit lower. And then it typically shortens your active pushing time. So that's the benefit to it. Obviously, we're not going to do it if we see any heart rate changes with baby, or if you're feeling like you want, you definitely don't have to labor down. If you're feeling like the urge to push, by all means, let's push. But a lot of times it's good for moms because it lets them kind of chill out. Especially if, I see a lot of moms love it and benefit from it if they've been laboring, they come in active and they're like, I definitely want an epidural. They get an epidural later, 6 or 7 centimeters. And then they, lay down after their epidural and get comfortable. And then they're 10 centimeters, their provider checks them and they just get to chill for a little while, at 10 centimeters and then push baby out in about 20 minutes. I mean, it works. It works really well. I'm a big fan.
I think the biggest benefit is just shortening that pushing time because you get to 10, you're so excited. Yes. Because you're like, oh my gosh, maybe this is, this labor's been long or it's just been hard or just you're excited to meet baby. Right.
Yes.
So it can be hard, but I think it's so smart. If your nurse is suggesting that to wait, because then you're not spending so much energy pushing. It's still going to be a big deal, but shorter. So then you're not as completely physically exhausted once baby arrives.
Yep. All right, if you heard that little baby crying, it's time for this week's segment of Birth It Up Babies. So this week I actually have 2. I have 2 kind of shorter reviews, but I think they're still definitely worth reading. So this first one is from Tiffany Lynn Hall, and she says, I took your Birth It Up course and it helped me feel so much more confident about my birth plan and experience. I already knew I was getting an epidural and I had a planned induction due to my hospital's protocols. I gave birth to a beautiful 9-pound, 2-ounce baby girl, Juliet. Ooh, big baby. I will hands down recommend your courses to any of my pregnant friends or those thinking of becoming pregnant. Oh, so sweet. And she sent me a little picture. She said she was born 11/6/2020 and is about to hit 4 months. She sent me that picture a few weeks ago. All right, the next one is from Abigail Jean, and Abigail says, "My birth it up, baby! Exclamation point, exclamation point, exclamation point. Lila is 4 months old, and I took the natural birth course at 35 weeks, and it's a good thing I did because my labor was only 4 hours long, arrived at the hospital 8 centimeters, and had her 40 minutes later. No time for an epidural." Wow, Speedy Gonzalez there. So if you want to hear more about the courses that these ladies took, go over to mommylabornurse.com. And we currently have 3 now. If you're listening to this episode, we have Birth It Up, the natural series, Birth It Up, the epidural series, and Birth It Up, the C-section series. So click on whichever one you want to take. All right. And now let's get right back into this week's episode. All right, so this next one is crowning or the ring of fire. So sometimes, as you're pushing, or every time as you're pushing, we will say that baby is starting to crown. So that's basically exactly what it sounds like. We're starting to see baby's head, emerge as you're pushing, the little crown of the baby's head emerging. And then the ring of fire is something that people feel. It feels like a ring of fire as you're pushing that largest part of baby's head out of your vagina. It can be very lots of burning, but it's very short-lived, and then it's over. So next one is, we'll talk about baby's positioning a little bit. So sometimes you'll hear your provider say, "Oh, baby's OA," or "Baby's OP," or "Baby's OT." And then there's certain degrees that baby can be OA, OP, OT in, like baby can be left or right OA, left or right, OP. And that's just, we're just kind of saying which way baby is in your pelvis. And it can be beneficial to know for us, like if this baby is OP, baby's facing, your front side. Okay, maybe we need to do this sort of position change to get baby into a more optimal position.
And the mom might have a little more back pain if baby's in that OP, or we call sunny side up. Because most of the babies are going to be delivered face down, and moms might not know that, if they haven't delivered before. But if they're in that OP, they're going to be born face up, and it can be a lot more back pain. So that's when your labor nurse can jump in and help with positioning or counter pressure to relieve that.
Yep. Absolutely correct. So the next one is, if you might hear decel or accel. Okay. And this is when we have you on the monitor. You've been on the monitor and watching baby's heart rate, and we're looking for certain things in baby's heart rate. One of them being accels. So accels are good. We like to see accels. Accels just are when baby's heart rate raises for a certain time period, and then it comes back down to baseline. So it looks like little kind of peaks of a hill in baby's heart rate. And that tells us that baby is doing perfectly in there, getting nice oxygenated, good blood flow from your placenta. So we like to see accels. We don't like to see as many decels. So when we talk about decels, if you could guess, is instead of baby's heart rate going up, it goes down. So there's a couple different types of decels. Some are benign, some are not so benign, but decels are like, it's like hard to go into, okay, what are early decels? What are variable decels?
Yeah.
But decels typically decels are not as good. So the last one I have is meconium or mech. Sometimes we call mech, just like pit. Sometimes we like to say things shorter because meconium sometimes is a mouthful. So meconium is basically if baby poops, sometimes baby, especially very overterm babies will poop inside, and it usually, almost all the time it's benign, and it just means that baby's term and baby has pooped and your fluid is a little bit green. But sometimes it can indicate that baby is stressed out. So if you do have meconium stained fluid, like your amniotic fluid is green tinged, we do want to make sure we're keeping a close eye on baby, and you might have some extra people in your room during your delivery, from like a pediatric team in there, a NICU nurse in there, just in case baby needs a little bit of extra resuscitation coming out. And sometimes we refer to it as mech. So,
yeah.
All right. Well, Lindsey, I will Did you have something to add from that?
No,
I'm sorry.
no, perfect. I was just going to say, we're going into this postpartum and breastfeeding terms.
Yeah, let's do it.
Choreo could really kind of go into the labor terms probably. So you might hear, your nurse say something like, oh, there's choreo. This is rare. It typically only, it's like 1% to 2%. And it's an infection of the placenta and amniotic fluid. So most likely you're not going to experience it. But if you do, they're just going to possibly give antibiotics, give a close eye. And that's also why they don't let your water be broken for days and days, because then that increases your chance of an infection. So that's what that term is, if you hear that. And then there's EBL. Or PPH. So EBL is estimated blood loss. PPH is postpartum hemorrhage. Okay. So nurses are actually trained, like I'm sure Liesel's been in lots of these little extra where we'll go in, how do we estimate blood loss based on pads, based on chucks, based on just like basically seeing it and estimating it, because we need to act quickly, right? If things like that are happening. And all moms are going to lose some blood after delivery. And keeping in mind and maybe speaking to your care provider, even before delivery comes, about, what are their practices? Are you going to give me Pitocin prophylactically afterwards? What are my options there, IV or an injection, and talk through that so you understand. I think what can get hard for moms is that some of these things are done prophylactically and there's great research behind it. But if a nurse just comes up and pokes a needle in their leg and they never knew that was coming, then that can feel like I guess it could be traumatic, or it could just be super unexpected and you're not knowing why it's done. So maybe you're thinking it's unnecessary. So it can be really great to talk with your provider through, what will your protocol be to take care of me and baby after delivery, so that you can talk through and feel good about those things. And then tearing. So typically all moms experience a little tear in their perineum if they're doing, if they do a vaginal delivery. And you may hear anything from a 1st degree tear, which is fairly minor, all the way to a 4th degree tear. And that's the worst that there can be. And there's going to definitely need to be repair and follow up there. So if you hear those, knowing, okay, 1st is, the least, and then 4th is the worst, just so that you can understand what that scale is. Right. And then asking about how you need to care, or if there's going to be any follow up there. Yeah. One that I didn't write down that I just thought of while we were chatting about was fundus.
That's a good one. That's a good one.
That's going to be a big one. Yeah. So typically the nurses are going to be massaging your fundus, or the top of your uterus, after delivery. And the more that we do that, the more we're kind of working out that muscle and reminding it to contract to minimize your risk of a postpartum hemorrhage. So it's not going to really feel that great. And you may be thinking postpartum, why does this lady keep coming in and pouncing on my stomach? Right. But knowing,
we're so mean.
But knowing what it's for. And then also you can kind of do it in between when the nurse is going to check. And then you're kind of controlling it just a little bit more. And on top of that, remembering frequency of breastfeeding is going to also help that uterus muscle to contract more. And the more it contracts, the less it's going to have a chance of having hemorrhage and more intervention. Right. Okay. So then another one here is AGA. So I think maybe we didn't cover, but there's like small for gestational age, there's large for gestational age, either at birth or, during pregnancy, we're thinking about that. Well, once baby comes out and the nurse is doing their assessment at whatever time, AGA is just appropriate for gestational age. So they'll kind of run them through a few little tests, and they'll just kind of look them up and down, and they might, mention that on your chart or to the pediatrician. And then EBF is exclusive breastfeeding. And that there can be a little bit of a, chitter chatter around this term as well, because it kind of seems like exclusive means, what does that mean? Right. And so exclusive breastfeeding, just all it means is baby's only receiving breast milk. So whether that's through pumping, and maybe that's all you're doing, maybe you're exclusively pumping, that still counts as exclusive breastfeeding. And, it's just a term we use to say that all baby's getting is breast milk. Right. It doesn't mean that that's the only way. There's mixed feeding. There's times where supplementation is necessary, but It's just meaning that baby's not receiving anything else. Right. And then people put letdown in there, and they said this was so confusing as to what this meant.
Ooh, that's a good one, because I remember learning about what a letdown was with my first one, and just my mind being blown, like, wait, what? How does this work? So please explain exactly what a letdown is.
And it's very interesting because it can happen in a couple different ways. Okay. It can happen through physical stimulation. So when baby's put to breast or you put the pump on, it just means like when that first tumble of milk starts to come, that's a letdown, right? And it might take 10 seconds for you. It might take 2 minutes, it goes back to the uniqueness of our bodies. And that doesn't matter, but the average is about 1.5 to 2 minutes for letdown. Okay. So it can happen it takes about 2 minutes for your body to send a signal to your brain, then says, okay, well, we better let milk flow. Right. But it can also happen just by thinking or hearing things. So by seeing a picture of your baby, by hearing another baby cry, a mom might feel a little letdown and a little milk gets released. So it can happen in a couple different ways. And I think the other thing to mention here is to recognize the difference of milk delivery from the breast versus a bottle. When we're feeding with a bottle, it's a steady rate of delivery, right? Baby starts getting milk immediately, and they get it at the same rate throughout the whole feeding. Versus when a baby's at the breast, it's kind of an ebb and flow. Okay. And women may experience as many as 4 letdowns during one feeding session. The average is 2. And the other thing to think about is you may not feel let down at all, but that doesn't mean that you're not having it. Okay. And of the moms who do feel let down, typically they just feel that first one. Okay?
I was going to say, I'm like going back through my Instagram story because I put up a box it was right after I started breastfeeding with my second one, of a box of like, try to explain what a letdown feels like if you feel a letdown. And there were so many different answers. Like some people said, oh, it's like an electric shock. And some people said, oh no, it's more like a tingle, or no, it's more like a chill. And I'm trying to find it, but I can't find it, of course. But so interesting. And I always noticed that I could see when I let down when I pumped, because I could see, the pump
dropping,
but faster. I wouldn't feel it in my body. But when I nursed, I would always feel my letdowns, except towards the end when my milk supply was like decreasing, I started to not feel my letdowns anymore. But like in the beginning, in the first few months, always felt my letdowns with breastfeeding, but never with pumping. So I think it's interesting how the stimulation is just different, and how your body is just different. For me, it was always like, I remember it kind of feels like rain coming down my chest. Like it's like a weird, like coming from my armpits and from my shoulders. It's like just kind of like a weird,
reminds me of the Friends episode where Rachel latches the baby.
There you go.
Oh, this feels weird.
Yes. Yep. Exactly. Yeah. It's
a wonderful weird. It can definitely be a wonderful weird, but you're going to have to experience it for yourself.
Yep.
But like you said, lots of women report different ways. A lot of times people will say it feels like tingling or warmth.
Yep.
And the reason why we say that and tell you that there's so much difference is so that you don't feel like, well, I'm not feeling it, I must not have any milk.
Right.
A lot of times we'll go down those rabbit holes, right? So rest assured, your experience and your sensation is probably going to be unique. And the other reason why I mentioned the rate of delivery is different is in the early days, when we're really, our goals are for breastfeeding, we don't want to introduce a bottle too soon, if at all possible, if there's no reason to, because of that difference in the rate of delivery. Yeah. So if we start giving a bottle, but baby hasn't mastered the breast, they will go to the breast and they'll say, well, I got to wait around 2 minutes for this, milk to get dropped off. What the heck? Right. And they'll get frustrated more easily, and it can be a more uphill battle from the beginning. Whereas if milk does need to be supplemented, put it in a spoon, put it in a medicine cup, put baby at the breast, and that can help kind of keep that breast focus there, all while getting baby those needed calories, because the one thing that's not time sensitive is learning to latch. Right. So I think it's important to understand that. And then if you get along your journey and you start giving more bottles, and then all of a sudden baby gets frustrated at the breast, you may go back to this concept of understanding, okay, the rate of delivery is a little bit different. okay, I'm going to check in with my breastfeeding goals. Yes, I want to keep going for a little more while longer. I want to interchange in between the two. Let me decrease the bottle sessions, increase the breastfeeding sessions, and see if that helps. So it's just like that little dance, but not to pull the ripcord and go, oh, I have no supply, or, oh, baby's never going to do this. Just take one step back, and readjust just a little bit.
Love it. Love it.
Yeah.
Well, let's do the last one. Donor breast milk and express breast milk.
Yes. Yeah. So, the WHO is going to recommend, okay, the first thing is mom's milk. If that's not available, let's go to donor breast milk. And if that's not available, let's go to formula. And so if you see that DBM, that's going to mean donor breast milk. And obviously you can ask your staff and things about that. And then express breast milk is just expressing your milk either through hand expression or a pump and then delivering that to baby.
Love it. All right, cool, Lindsey. Well, thank you so much for coming on here and talking about all of these terms. So we just decided that we're going to split this episode up and have Lindsey come back on for you guys next week and talk more about. We could talk
for days and days.
We could talk days and days. Like I said, she's going to come on for a third time and talk about her own personal story. But I think we need to split up terms and get next episode talk about some more breastfeeding questions, because you are the expert when it comes to breastfeeding stuff. So we would love to have you
lots of questions, lots of questions from the Mommy Laborers community.
Lots of questions. There's always lots and lots of questions, which is good. We love that. So Lindsey, thank you so much for coming on here. Can you just remind our listeners, they're going to hear you next week when you come back on, but can you remind our listeners where they can find you on social media?
Of course. So for sure, hop over on Instagram and give us a follow at Lactation Link. We're typically sharing daily tips. We have weekly Q&As, lots of great engagement with other parents just like you over there. So make sure to follow us there. And then if you're ready, if you're pregnant or you're in the weeds of breastfeeding, hop right into a course. We have 3 different courses: breastfeeding basics, breastfeeding hurdles and how-tos, and then pumping and storing breast milk. We also bundle those into all 3 into the confident breastfeeding course. And that's 90% of people that jump into that one, because it's the best value and there's really no information you don't need within those 3. So those are great. And then if you want to give us a test drive, we also have free workshops where you can kind of come in, take a look at our teaching style and that kind of thing before you jump into a course. So would love to see you guys. And then once they're in there, they get, unlimited access. We actually have all our content inside an app. We have weekly office hours with our experts in there. And so you can access your videos, which are broken up into 2 to 5-minute snippets. You don't have to sit there for a full hour if you just want an answer to one question. And then you can talk with other moms in there. I'm in there answering questions regularly as well.
Very cool. I love it. We'll put all that stuff in the show notes page. And I can't wait to talk to you next week, Lindsey, about some more breastfeeding stuff.
Thanks so much, Liesl.
All right, guys, that wraps up this week's episode. Thank you so much for tuning in and letting me be a part of your motherhood journey. It is truly an honor. If you like what you heard, don't forget to hit that subscribe button so you never miss an episode. And I love hearing what you guys think of the podcast. So if you're liking what you hear or you have a suggestion, I'd be so grateful if you'd go ahead and leave me a review wherever you're listening to help more mamas just like you find the show. That's it for this week on the Mommy Labor Nurse podcast. What do you think? Are you starting to feel a little more confident about your pregnancy and birth? Well, if you want more, be sure to head on over to mommylabornurse.com/podcast for today's show notes and a library of episodes so you can keep getting educated before your upcoming birth. And while you're over there, be sure to check out the blog and learn about our online birth classes. Find it all and more over at mommylabornurse.com/podcast. See you next week. Same time, same place.